Now, if you look at the clip itself, the choosing of the clip also has to happen. So there are these 4 generations of clips which started from 2003, and now we are at a point where you have the clips which are sort of longer, they are wider, and they're more flexible. So they have these numbers, the alphabets which are there. So presently we are using the XTR, and then the NTW or the XTW are the bigger ones. So those of you are interested in all these numbers, so this is what it tells you. So there is this arm length, you have the width, and you have these, the outer diameters. So you look at the French also, it's about 25 French. So these are really big catheters which go in. And what is new about the new generation is that they are not only just longer and wider, but what is sort of really useful to the interventionalist is it gives them the ability to grasp independently what we call as the arms. So that is where the real value is. Now, the steps per se, so there are, enough sort of publications. So they have these various sequences. So I have put in my own. So you have the transeptal puncture, then you have the guide catheter, which is going in, sort of makes way. And then you have the actual clip, which is going to come in. And once the clip comes in, then it's all about how you position it and how the trajectory is going. And then this is above the valve. And then there is going to be imaging below the valve. And then finally the leaflet is grasped, and then the clipping finally takes place, and then afterwards the final withdrawal of the clip delivery system happens, and then looking at the interatrial septal for any defect assessment. So what are the views? So there are sort of very standard views, very sort of protocol sort of approached views. So you have the the mid-esophageal 4-chamber view, then you have the short axis, the bicommissural view plays a really big role, and the long axis also along with this. So these two sort of, the bicommissural and the long axis play a huge role, and the bicaval for the transseptal puncture. And the modalities, the 2D and the X-plane or the biplane, depending on which vendor you're talking about, and then 3D color zoom, and then even now the sort of now it is all about the multi-plane sort of projections, which are sort of being used a lot more, because you get everything at one go, you get all the views and as well as the 3D also, and then use of this color comparison simultaneous. So I'll just sort of run through a lot of images. They are primarily sort of, a few patients. So this sort of tells you more about how it is done. So the first and foremost is, as soon as the patient is on the table, you are sort of, already this patient has gone through the sequence of being, selected, planned and optimized in terms of therapy and all those things. So here you just do a lot of, scout imaging, and sort of these are for reference images. You want to compare it later. So you go through the sequence of, having a zoom view, and then you'll put on the color, you quantify the color, and sometimes even having this dual image, you are looking at the regurgitation from both sides helps. And the last two are very, very important. So the pulmonary vein and the gradient. So the pulmonary vein, as you can see here, you have a very low S wave and a very sort of tall and a big prominent D wave. So this is used for comparison later. And then the gradients, of course, play a big role. So you have to have this here. Then the septal puncture itself. So this is, this is again has its own protocol. So you have these 3 big sort of views. So one is the bicaval view, and then you have the short axis views also. So once you have identified the puncture points and where you're going to do, then you're going to look at the height. So typically the height is for the secondary MRs, the functional MRs, you sort of go a little lower down because the coaptation is at a lower point. And those who have prolapse, the more severe the prolapse, the segment which is coming up, that means you have to go a little higher. You need a little height for the delivery system to be maneuvered. And once you have sort of fixed on this height, and then you fix a point, and then you have the agreement with the interventionalist, then the actual process of trying to find where the exact point is done. So this is where the needle is being brought down. And then the important point here is that the tenting has to happen. So there has to be a clear tenting which has to be seen. So you can see that this is the bicaval where the tenting is happening. At some point you decide to go for it where you have to be a little superior. So you can't go too inferior. So that point is fixed. And then you go to the short axis also. You don't want to go too close to the aorta. You don't, because these are really big catheters. You don't want to sort of get into trouble with the aorta. So you sort of go a little posteriorly. And then finally, the fourth chamber, you sort of again confirm where the tenting is and look at the height, and you already decided earlier, so you sort of fix that. And then once it is done, then the go ahead is given, and then the puncture is made. And this is usually seen in the short axis or the X-plane of the bike. Now the story now shifts to the left atrium. So what is going to happen in the left atrium? So you have these wires which are going to come in, one for the LA pressure, and then you have the guide catheter wires, the stiff wires come in. And then at this point, you're still sort of, giving some insights to the interventionist about what's happening. And you sort of go to the top of the roof of the LA and you try to see what is happening with it. And once the LA pressure catheter is in place, then the steerable guide catheter is brought in. So this is pierced through with a dilator, with the help of a dilator. And then it's very important that this has to be sort of shown all the time, because you don't want this steerable guide catheter going too far across and injuring the far wall of the left atrium. So if it is there, sort of, you tell the interventionalist to withdraw a little bit, and you don't want too much of withdrawal also. Somewhere around 2 centimeters it should be across the septum, because you don't want the catheter to slip back also. So once this is done, then you know that the guide catheter is in place, and then the 3D again tells you where exactly the position of the guide catheter is. Then once the guide catheter is in place, then sort of the sheath withdrawn, and then the clip delivery system is inserted. So this is again seeing from both the bicommissural view as well as the long axis views. And then you can see that this is the initial sort of trajectory, which is not right. So you have to have that cursor in between, and the alignment of the clip delivery system with the cursor has to be there, so that in one view you see it as one image, in the other view you see later on I'll show you when the arms sort of open up. So here you're trying to sort of tell the interventionist where to sort of in what trajectory it is going. So you can see that it's a little more anterior, going towards the aorta. So you start guiding the interventionist to say that you have to go a little posterior, and you go back to the bicommissural and say that whether it is medial, lateral, and then 3D to some extent helps, but most of the time it is going to be 2D at this point. And then once the trajectory is sort of fixed, and then they have got it right, so then you are sort of you want to know whether you're directly over the jet, and you start to use the zoom view a lot more now, and then you put the jet on, and the clear sort of splitting of the jet has to happen. So the clip has to be sort of the delivery system has to be above the piece, so to say. So it has to be across the jet itself. So once that is confirmed, and then you again do a 3D, and then go to the LA side, and then you look at it, and then once that is done, then the delivery system is started to push a little further forward, and then as you can see here, it's partially open, and then it is maneuvered into the left ventricle here. So at this point, the left ventricle is sort of being approached, and the main point is to catch these leaflets. So as soon as the clip delivery system is beyond the leaflets and it is close to you don't want to go too deep in, you don't want to get into trouble with the chordae which is around, and you sort of gently sort of move it up, and then you try to catch the leaflets. So this can take a little effort, and it takes a little time, and then you might have to go back and forth because sometimes the rotation gets goes in the wrong direction, and then it's important to catch both the leaflets, as you can see in this the top right image over there. So it is important that the symmetrical capture of the leaflet should be there, and enough length of the leaflet should be there, because you don't want a clip to be detached later. And then in between, you're going back and forth with the 3D, and this is the coaptation line, and then the coaptation line, it has to be perpendicular to the coaptation line. That is number one rule. And then the iota also. So there is something called as a 12 and 6. So it has to be at 12 o'clock, and these two clip arms, as you can see, they should be in this 12 and 6 direction. So again, you're going to sort of put on the color and see whether it is over the jet itself. And once it is beyond the mitral valve, the gain may have to be reduced, because the tissue has to be removed as far as the leaflets are concerned, because you need to see the clip much better. So this is an sort of you reduce the gain quite significantly, and you see the clip arms over there. Now, at this point, the positioning is there, and then everybody's satisfied, and then the grippers come down, and then they hold the leaflets. And once that is done, then the clip is gradually closed, and then bit by bit it is closed, and then it is firmly held in place. And then once that is done, then you recheck for the regurgitation. So here at this point, if it is for some reason it is not correct, you sort of open it again, and then you go through the whole process and you start from the beginning once more. But once it is done and then the regurgitation stops, your of course the LA pressures on the monitor will be there. From the echo side, you start to see the S wave. So the S wave starts to come up now as the LA pressure drops, and this is an important documentation that needs to happen. And at this point, you also want to look at the gradients. So generally, you don't want gradients to cross for 5 mm, the mean gradient of 5 mm Hg. And you sort of go through this. And typically in the secondary MRs, you don't, these are really big sort of orifices. You don't get to have any problems with the gradients. It's more with the primary MRs where you see this. And then once that is done, now the clip delivery system has to be removed. And here again, one has to be careful because now it has got its sharp edges. So what they call as a spear. So gradually it is taken out. You don't want any damage to the atrial wall. And then finally it is taken out. And there's always going to be some amount of residual iatrogenic ASD because these are really sort of, as I told you, about 25 French, they leave a big sort of hole. But generally they are left, nothing is to be done. You just monitor it. And then you sort of do the imaging and then check these are more for, finishing of the procedure itself. So this is how it sort of, the guiding is done. So now just a brief look at another patient. So this is a primary MR patient. So here you can see that there is a prominent prolapse segment over there and significant MR is over there. And again, the puncture is done as per the previous patient. So the same sort of protocol is followed. You see the steerable guide catheter across that the tram track or the rail track as they call it. The bottom right shows you the prominent steerable guide catheter. And then you go through the same process of looking at the clip and is it aligned in that, it should be perpendicular to the coaptation line and then it should be in that 12/6 and then you capture this. So this is an example of you can do it even for the primary MRs or prolapsed leaflet also. So here you can see that the gradients are sort of reaching to 5, so you don't really want to cross this, and you have to be careful because you don't have room for one more clip if at all, if it is needed, but in this patient it was not needed. So my final few slides before I close. So other additional points which I would like to stress is that you can utilize the MPR and you can sort of do it to localize the jet, the character of the jet itself, and even during the procedure you can actually use it as a live sort of a method. And then here an example of how the trajectory you can guide. So here it is more anterior, and this the other image which shows that the clip is going in the posterior direction. So you sort of guide the interventions, tell them to change the trajectory. And 3D to some extent gives you some nice images. Maybe at the time of the procedure things are moving too fast, you may not have much time, but it's very difficult sometimes to identify the catheter and the wire, and but you do get some good pictures sometimes. And then here this is a view from the left atrial side. You can see that the catheter has come, and then you have from the annulus where it is, and then this is a transgastric view of how the clip looks like. These are more sort of sort of mopping up images at the end of the procedure. You get to see this. And as far as the clipping is concerned, it's typical Alfieri where you have the clip in the center and you have this figure of 8 and you get a nice orifice of 8 with the central sort of clipping which is there. And things can go wrong, and you can have a residual MR, if there is, these are problems which can happen later, where you can have the leaflet sort of coming out, escaping, and then you can have a tear, or you can have remodeling of the chambers, especially the left atrium, and the MR can increase over time. And these are the various complications that can happen. So we don't want this, but these are which have been reported. So you can have effusion, thrombus, clip detachment, and then you can have the mitraclip entangled in the chordae also, and then the iatrogenic ASD also can be quite significant sometimes, and then of course bleeding and vascular injuries, and especially gastrointestinal injury if you've been too aggressive using transgastric imaging. So that would be how the clip would be guided. Thank you.